Good morning, ladies and gentlemen. Thank you very much for inviting me to talk this morning. My husband was at university in Leeds, and I have some very fond memories of the city, but it looked almost unrecognisable, apart from the fact the station is still quite as bad as I remember it many years ago. In fact, actually, it's even worse. But this is beautiful, right? A lovely building. So I've been asked to talk to you about drugs other than imatinib and when you might use them and how we decide which drug to use in which person. And I think there's going to be a little bit of repetition because, of course, a lot of these choices are based on things like side effects and mutations, so you're going to hear the same sort of things again. But let me start by saying, if you started on imatinib, then the reason that we would suggest change to an alternative drug would be if you weren't responding very well to imatinib, and we call this resistance. And I'm going to come back to the slightly subtle nuances of defining resistance in a moment. The other reason, of course, and possibly the more common reason for changing drugs, is if actually you just don't get on very well with imatinib, so that we refer to this as intolerance. And many of you will have been intolerant to one or other drug, so you'll know exactly what I mean. So why are we so careful about this? Well, this is a set of slides that I have borrowed from Tim Hughes, who's a very well-known CML expert who is normally in Adelaide. And basically, this is the next few pictures show you what happened to people when they start taking these drugs. So approximately 10% of patients start on imatinib and just don't respond at all. And then another 10% start on imatinib and their blood count goes back to normal and they reach maybe a cytogenetic, even a molecular remission, and then they stop responding. So the first one is called primary resistance because you don't respond at all, and the second is secondary resistance. These individuals are the individuals that are most at risk of getting into trouble with their CML, so they're the individuals we want to identify as early as possible. The vast majority of patients actually end up either in the other two categories. Either people respond very well but then sort of get stuck at a certain level so that they don't ever really become candidates to stop the drug, but the disease is really well controlled. As long as you keep taking your tablets, nothing's going to go wrong. And then there's about 50% who have these fantastic deep responses who become candidates perhaps for a trial of stopping, and we know that about half of them will be able to do it, and half of them will have a rise in the PCR and won't be able to do it. Now, in various guises in the previous talks, you've seen something very similar to this. So this is the European Leukemia Net consensus definition of whether you're doing well or not on the drug. And Jenny explained it very well with the different set of slides in the previous talk, so I'm not going to elaborate too much. There's also a set of guidelines in the United States, which is called the NCCN guidelines, which are slightly different from the European, but not significantly different. And you would be forgiven, I think, if you're sitting in the audience to think that actually you could probably manage your CML at home if you had a table like this, right? Because it's pretty straightforward. And if I'm at this point at this month and another point at another month, I should change my drugs. So I might as well just not bother going to the hospital, apart from the PCR test. So we would definitely want to change your drug if you were truly resistant. So that would be a failure, an ELN failure. It would not, as Jenny said, necessarily be if you were suboptimal. And we certainly wouldn't want to change you if you're tolerating the drug, if you're doing well. So resistance defined as failure to reach ELN guidelines. There are other situations where we worry a little bit about patients and might be more ready to change their treatment if they're not doing optimally. And that's if when you had your chromosome analysis at diagnosis, they found not only the Philadelphia chromosome, but another abnormality. And commonly these are things like 3 copies of chromosome 8 or only 1 copy of chromosome 17, or even an extra Philadelphia chromosome. Got the double whammy there. And the other thing we do with patients when they first come to see us is that we can define a level of risk for you. It's not perfect. I'll try and explain what I mean by that and how we do that in another slide. But one of the reasons we emphasize that you do need to go to your local haematologist and not sit at home with the ELN table and do it yourself, is that there are some subtleties in how we decide whether you're responding or not. So if you're probably the more common situation that when you are diagnosed with CML, your PCR result is somewhere around 100%. It is never 100%, but it might be 60% or 110% or 92%. I think if we went round the room, you'd have a big range of what your PCR was at diagnosis. And then if you get to 3 months and your PCR is 11%, if you just looked at the table on the do-it-yourself thing, you'd say, oh, I need a change because I haven't reached the magic 10% figure. But if you've gone from 110% to 11% in 3 months, I'm really happy with you. I'm not going to do anything with you because you're going in the right direction. And that's what Jenny was meaning about how sometimes we wait to see what happens at the 6 months. If, however, you're one of the less usual patients whose PCR at diagnosis is only 9%, right, and at 3 months you're 11%, you're clearly not doing very well at all because nothing's changed for you. The drug has had no impact whatsoever. We need that slope to be going downwards. So this patient I would leave on, and this patient I would change. Now, when you're truly resistant, you've also had some conversation about mutations, and I suspect lots of you know about mutations because it's something that everybody fears, that they might get a mutation. This is an attempt at a three-dimensional picture of what BCR-ABL, the protein of BCR-ABL looks like, not the gene, but the protein that is causing the problem in your cells. And it's got a little groove here. I think you've sort of seen schematics of that. And this pink and blue thing here, that's imatinib, and it fits into this space and stops the protein working. But if there's a mutation in one of the elements of this three-dimensional structure, I call it a ball of string, actually, or a ball of wool, because, I'm not that clever. If you've got a little mutation in it, it's very easy to see how if the shape changed a bit, imatinib either couldn't get in or got in and fell out very easily. So we do look for a mutation when you're resistant. And this is quite an old slide now. There are 54 different mutations on that slide. There's now over 100 mutations of BCR-ABL described. Not all of them impact on your ability to respond to the drug, but some of them very definitely do. And so we commonly in practice have what we call the traffic light slides. So if you have got one of these mutations that's listed down that side, and there isn't going to be a quiz afterwards, so you don't have to remember what they all are, we will look at this and we will say, well, this one is sensitive to bosutinib, but it's not so good on imatinib. This one's not so good on nilotinib. So it helps us choose. It helps. It's not absolute, but it helps us choose. The red one means stop. And the problem for us, until we got ponatinib, is that the T315I mutation, which everybody fears, was resistant to everything except ponatinib. So these things are helpful for us. So that's why you have to have a mutation done. For people who present in chronic phase and don't do very well with imatinib, I would say the chance of you having a mutation is probably less than 10%. So it's not a big deal. So you shouldn't panic about it. It's a relatively rare event. I explained to you that we try and calculate risk for you. So this is the risk of not doing so well on the TKIs. And over the years, there have been 4 different scores: SoCal, HASFOD, UTOS, and ELTS. And the reason there have been 4 different scores over the years is because SoCal was when we only had busulfan. HASFOD was when we only had, we had busulfan and interferon. UTOS was when we first got the TKIs and we were trying to make it very much more simple. And the ELTS, which is the latest one and probably the most accurate, takes into account all the data we have about all the TKIs now. You will see that all the factors that go into ETLS are exactly the same as the factors that went into the SoCal score that was described in 1984. It's just that there's a sort of algorithm where you multiply the age or the white cell count by a slightly different number, and you get a better distinction for good risk and poor risk patients. Why does this matter? So patients on these scores are divided into low risk, which I've shown here in grey, intermediate risk in red, and blue in high risk. And the Italians have taken what they call a real-life study. So that is taking people who started on imatinib but weren't in a clinical trial. So just normal going to the hospital, getting imatinib, you weren't in a clinical trial. And what it shows is, although the results for everybody are really good, right? I mean, 87% is really good for the doctor. It might not be so good for people sitting in the audience. But if you're low risk, your chance of surviving on first-line imatinib is wonderful. In fact, the drops on the curve are because you got knocked over by a bus, not because something had happened to you with your CML. The 86% is the individuals who are at high risk, and indeed some of those did have a failure to respond to the drugs or disease progression. And the intermediate risk is in orange, and you can see it's in the middle. And if you instead treat everybody with a upfront, first line, first drug, a second generation drug, so in this case happens to be nilotinib, but it could be dasatinib or bosutinib, you see that the intermediate risk go to the same outcome as the good risk, whereas the poor risk remain about the same. So if you start imatinib, but you were an intermediate or high risk at diagnosis, and you're not doing that well at 3 or 6 months, we may be more encouraged to swap you early than later. And similarly, I mentioned that sometimes people have additional chromosomal abnormalities at diagnosis. Now, the details are written here, and you mustn't get panic about that either. But the Americans have identified, rather confusingly also, high risk, intermediate risk, and standard or good risk cytogenetics. Now, if you look at the numbers of patients here, you can see the vast majority of patients are either standard risk, which means they only have the Philadelphia chromosome and nothing else, or the very low intermediate risk. And actually, it's quite rare to have another chromosome abnormality at diagnosis. But it does distinguish people who are going to fail imatinib. So if you had an extra chromosome abnormality and you weren't doing that great at 3 or 6 months, we may be more encouraged to change you than not. One of the big reasons we change people who are doing well on the drugs is because they don't tolerate them very well. They get a lot of side effects. Now, by definition, intolerance means you're responding to whatever drug you're on, right? So there shouldn't be any confusion in that. It's just that you don't like taking it or you can't take it because of the side effects. And there's 2 main causes of intolerance. One is blood-related. And I will try and do these in colours that are appropriate. So you may drop your haemoglobin, so you become pale pink instead of bright red, and you're a bit anemic. You may have low platelets, and that runs the risk of you having these little blood spots, which is why that's meant to be little blood spots. Or you may have a low white cell count, which may mean that you're susceptible to infection, so the yellow's meant to indicate pus, so that you can remember that. Now, if you have a blood-related problem on one of these drugs, that is a problem for us because the drugs work in a very similar way. So if you have low platelets on imatinib, very likely you're going to have low platelets on dasatinib. So that might be something we have to work around, either tolerating a much lower platelet count and telling you not to play in the Rugby World Cup this week, or if you've got a very low white count, we might have to help you a little bit with injections of white cell growth factor, so that we'd rather keep you on the drug and get this everything normalised. Then you can have non-blood related side effects, and Dragano is going to talk to you lots more about side effects later, so don't want to go on too much. But again, many of you in the audience will have had some of these side effects. So if you feel a bit green and nauseous, why can't I say that word today? You have tummy upsets, you all know that. You have sort of jippy tummies and loose stool. Skin rashes, joint and muscle pain, very common, cramps, fatigue, big problem on imatinib, and occasionally liver damage, so you go a bit yellow. That's why the thing is yellow. So, if you've had one of those side effects and you aren't tolerating whatever drug you're on at the moment, and let's say this is second line, you've probably been on imatinib. And when we know you're intolerant and not resistant, so all we have to do is we have to choose the right drug for you. We have to choose the right drug for your lifestyle, we have to choose the right drug for your side effects, and we have to choose the right drug just in case you have any pre-existing medical conditions. So if I go through the drugs that are available in alphabetical order, bosutinib is very well known for anybody who's tried it to cause nausea and particularly quite vicious diarrhea in the first few days. So if you've previously had a lot of problems with your gut, that might not be our first choice. The most significant side effect is that a small number of patients end up with abnormalities of the liver that we just detect on the blood tests. We don't let it get bad enough that you have any real liver damage because it's all reversible. But if you've had liver problems on the first drug, we wouldn't choose bosutinib. And if you've had a terrible rash, well, I'm sorry, because all the drugs cause rashes, so we just have to suck it and see whether you'll get away with the next one. So I'm going to show you the other drugs in the same sort of pattern, and I won't go on too long about it. Dasatinib also causes rashes. It has this side effect that Dragna will talk about more in the next session, where you can get a little bit of fluid accumulating not in your lungs, but in the two membranes that line your lungs, which we call a pleural effusion. And very, very rarely, there can be a problem with the pressure in the lungs. So when we talk about hypertension here, this is not arterial hypertension where you have your blood pressure measured and it's a little bit high. It's a problem directly in the lungs. And nilotinib is going to look awful. I'm sorry about that, but I mean, I think nilotinib's a really good drug, so if you need nilotinib, and often when people have been very tired on imatinib, they love going on nilotinib. If they put weight on imatinib, they love going on nilotinib because they lose the weight. So also rash, also liver damage, high cholesterol. So if you've already got a high cholesterol and you're already on a statin, it might be a drug we avoid. High blood pressure, this is really hypertension, so when you have your blood pressure measured, it's high. Unfortunately, occasionally thrombosis, most commonly in the lower limbs. We call that peripheral arterial occlusive disease, sometimes heart attacks, sometimes stroke. Incidence probably about 10 to 15% if you've been on nilotinib 10 years, and very much associated with pre-existing problems that you might have. So if you are already have a high blood pressure, if you've already had a heart attack, if you've already had a stroke, if you have a strong family history, if you're overweight, if you smoke or smoked, or if you have diabetes, this is not the drug for you. And similarly, if you have diabetes, it can make it a little bit worse. If you haven't got diabetes, it can precipitate it for you. So it is a drug that we're very careful about. Ponatinib, rash, very dry skin, can cause a problem with the pancreas, which is the organ that produces insulin that sits near the liver. The other drugs can do it, but probably ponatinib more. Still pretty rare. High blood pressure and thrombosis. And ponatinib is a drug that causes thrombosis more than any other. So the incidence is probably 30 or 40% if you were to stay on ponatinib for a long time. Now, I can imagine that anybody who's sitting in the audience who's having to consider one of these drugs or who's on one of these drugs might now be a little bit worried about that. I need to tell you that we didn't anticipate these problems when we started patients on these drugs. Fortunately, all the patients who started them in clinical trials. So the really good thing about clinical trials is information is gathered in the clinical trial, and if something is happening to people that seems to be higher than either in the control arm or in the normal population, it's reported by the drug company. I mean, people are sometimes frightened by clinical trials, but being in a clinical trial is a really good thing. So we did not anticipate these problems, so we were probably not as good as we should have been about controlling all these problems before you start. And I think Dragan may mention this again. I suspect the risk of these things is a lot less now that we worry about your cholesterol, we worry about your weight, we worry about your blood pressure, and we make sure that you don't get the wrong drug if it's not suitable for you. So we also have a traffic light set up for which drug we choose, and that depends sometimes on the side effects you've had, but more consistently with pre-existing diseases. The median age of onset of CML in the UK is between 60 and 64, which means 50% of people are over that age. And if you're over that age in the UK, you stand a very good chance of having high blood pressure, having a high cholesterol, or being diabetic. So if those things exist in you anyway when you need to change the drug, we probably wouldn't give you nilotinib. If you're a long-term smoker and you've got bad lungs, you've got emphysema, we probably wouldn't give you dasatinib. If you're a heavy drinker, even if you don't admit it to us, we can tell on the blood tests, we probably wouldn't give you bosutinib. So we have a kind of guide like that. So if you are on imatinib and you need to change the drug, how confident are we that the second drug will work? So these are the results from nilotinib, which was given to a lot of patients because they weren't doing very well on imatinib, either because of resistance or intolerance. And what we want everybody to achieve in the first instance actually is this purple histogram here. So it's called complete cytogenetic response. Of course, we can get your blood count under control, and this antique of major cytogenetic response is something that crept into all the clinical trials, but we don't care about now. So if you end up needing a second drug, you've got about a 40% chance of responding to it. 40 or 50% chance of responding. Probably 50% now because we changed you earlier. How long should we try the second drug? Well, you heard a lot about being under 10% at 3 months on your first drug. It works very well for the second drug. So the green is, this happens to be dasatinib, is the patients who had dasatinib as their second agent and got a PCR under 10% at 3 months, compared to the red line who was more than 10% at 3 months. So you've got a pretty good idea after 3 or 6 months whether this drug is going to be suitable for you. And that's important to know because you may need a further change. So you shouldn't hang around too long. If you do need a third change, so if you needed to go from nilotinib, so you've started with imatinib, you've been given nilotinib, and you need to go to another drug, lots of doctors will give another, what we call second-generation agent. So if you fail nilotinib, they'll give dasatinib or bosutinib. If you fail dasatinib, they'll give bosutinib or nilotinib. If you fail bosutinib, they'll give dasatinib or nilotinib. But if you look at the average response, so it varies from 11% to 30%. So you've got a 20% chance of responding to a second-generation drug. So increasingly, if you're suitable for a third-generation drug, which at the moment the only one available is ponatinib, we would encourage you to think about an early switch to that drug. Because if you have ponatinib as your third drug, you've got more than a 50% chance of responding. And if you don't respond to the ponatinib, you'll hear later that there are clinical trials, and there's a drug called dasatinib that we have great hopes for. But if you're young enough and fit enough, bone marrow transplant is still a fantastic option for this disease. It's how we treated everybody until the year 2000. It's very scary, but it's a very effective treatment. And if you're somebody who's failing all three of these drugs, transplant remains a very good option for you because you're probably not going to respond to a drug. Now, I don't want to alarm anybody because it's about 5 or 10% of the total population, but you shouldn't hang around too long, is what I'm trying to say. So the choice of your second drug depends on the presence of mutations, the pre-existing medical problems, which we call comorbidities, previous side effects, and convenience, because dasatinib and bosutinib are once a day, and nilotinib is twice a day, and requires the food restriction before and after, which is probably why people lose weight when they go on nilotinib. So if you put on a lot of weight on imatinib, it's probably a good option. Now, I've finished, and I'm going to do some shameless advertising now. So, we are sitting in the UK and we moan constantly about the National Health Service. Actually, many of you in the audience may not moan about the National Health Service because probably you've had your leukemia diagnosed, you've got highly effective treatment, your doctors are nice to you, you get to know them very well, and actually you thank your lucky stars you're living in Britain and you have the National Health Service. But if you open the newspapers or if you put on the TV or the radio, you hear nothing but bad things about the NHS. But imagine you have CML in India or Gambia or Madagascar. There's no National Health Service and these drugs are very expensive. So there is a program called the Max Foundation, which was named after a little boy called Max, actually, who had CML. And they've been working with the drug companies, particularly Novartis in the first instance, but increasingly with the other companies, to make these drugs available in countries that are not as fortunate as we are. And literally at the weekend, I heard this presentation that they were able to get 63,000 patients on this GPAP program in 93 countries, with a population of over 71 million. And what they did was they checked the last time they picked up drugs, so they knew that they were alive. And if you look at the survival of the CML patients in those countries, in the blue line, it's considerably better than a patient in that country who doesn't have CML at all. So the moment you've been diagnosed and you get the drug and somebody starts looking after you, they look after your whole health. So the GPAP program has made such an enormous difference to patients living in these countries. And what we now need to do is educate their doctors, and we have been educating their doctors. So the International CML Foundation has been paying for doctors from emerging countries to come to centres of excellence in the UK and all the rest around the world to learn how to look after CML and then go back and access the GPAP program. And many of my CML colleagues, not me, I hasten to say, very fast, are climbing Kilimanjaro next month. And they are climbing it for these programs to educate doctors so that they can deliver the drugs in countries that are not as fortunate. So if any of you have a spare fiver, just go online to the International CML Foundation and see if you'll sponsor Tim Hughes and Mike Deinager and Jorge Cortes, who actually have all done so much for all of us, physicians and patients and nurses, healthcare professionals, to get these drugs to market and return your life expectancy to normal. So if you can, please help them. Thanks very much. And I'm going to take some questions now because we need to swap the computers. You put them off, Kate.
Oh, I'm sorry. I didn't mean to put you off. We're just moving time on.
Computers are being swapped, so plenty of time. I'll go away then.
Please do.